Hello, can you guys hear me well? Hello?
Yes, sir.
Okay, that's great. So, before discussing leukopenia or leukocytosis, we should know that what's the normal level of your leukocyte inside your body. So, in the pathoma, it's written 5 to 10, but it's considered to be 4K to 11K, right? In most of the other literature books, okay, or most of the other pathology books. Okay, please just give me a second. Okay. So we were discussing leukopenia and leukocytosis. So when do we get leukopenia, right? We get leukopenia whenever we have some drug toxicity. What do I mean by that? For example, we know that the leukocytes are actively dividing cells. Like whenever in the body you have infection, these are the white blood cells, the policemen of your body are going to be actively dividing cells in order to fight off that infection. And we know that normally our body is exposed to a lot of pathogen. It means that the activity of your leukocytes are really high at the baseline because they're always fighting off against some kind of infections. So it means there should be an actively dividing cells. So for example, if someone is on chemotherapy or alkylating agent, that is anti-cancer therapy, for example. So we know what is the main goal of anti-cancer therapy. We are basically decreasing the division of actively dividing cells, and cancer cells are your actively dividing cells. But along with that, we can also halt the activity of your white blood cells, which are also your actively dividing cells, right? So those who are just using any chemotherapy, alkylating agent, so it can cause damage to the stem cell, and as a result of that, it can cause decrease in your white blood cell count. Before discussing the neutrophils and these entire white blood cells and lymphocyte, you should know the normal lineage, right? We know that we have hematopoietic stem cell. They have CD34 on their surface. We have two lineages, the myeloid lineage and the lymphoid lineage. We know that, right? From the myeloid lineage, we have erythroblast. Erythroblasts are immature red blood cell. Keep that in mind, right? Blasts are immature. Whenever you see blasts are immature. That's really important to know because we'll be just discussing that in acute leukemia, right? Okay. So erythroblasts are then further going to mature into your red blood cell. Okay, we know that. We have myeloblasts. Myeloblasts are immature cells, and once they get mature, they can be converted into granulocytes. For example, what are your granulocytes? Neutrophils, basophils, and eosinophils. We have monoblasts. They are immature, right? And once they get mature, they are going to convert into monocytes and further into macrophages. We already know that, right? Then we have megakaryoblast, right? Megakaryoblast are, immature platelets, right? So once they get mature, they are going to be broken down into pieces and converted into megakaryocyte, which further are going to give you your platelets, right? So this is basically your myeloid lineage. Keep one thing in mind: all of the blasts which are mentioned here are your immature cells, while the sites are mature, right? Sites and blasts, you should be knowing the difference, right? Then we have our lymphoid lineage. We discussed lymphoid lineage in a big detail in our immunology section. We have B lymphoblast, T lymphoblast. Again, they are immature B cells, immature T cells. Then immature B cells are further going to be converted into naive B cells, and naive B cells further are going to be converted into plasma cells. What are naive B cells? You can simply think that they are inactivated B cells. Whenever they aren't exposed to any antigen, your the dormant B cells, naive B cells, they won't undergo their activity of producing their antibodies. Keep that in mind. So somehow they are kind of immature B, right? So the blast is, really immature. You can simply think of that it's a 5-year-old blast and this is 14-year-old blast, right? So both of them are immature, but you can just simply make a concept that blast naive B cells aren't exposed to antigen. So it means they aren't mature because mature B cells have the ability to make antibodies. We know that, right? Okay, then we have our lymphoblasts, the T lymphoblasts. T lymphoblasts further are going to be converted into naive T cells, which aren't exposed to any antigen. And further, they can be converted into CD8 positive killer, we know that, and CD4 positive that are your helper cells. This is the normal lineage, right? So those who are on chemotherapy or alkylating agent, it can cause damage to the stem cell. For example, if hematopoietic stem cell is damaged, we can't make enough neutrophils, which is going to lead to neutropenia. Penia is less neutrophils, right? Okay, severe infection. So there is difference between infection and severe infection, right? For example, let's suppose if I have a tissue here, let's suppose you can take an example of hand tissue, right? Let's suppose. If we have any kind of cut on that, and we have a lot of bacteria growing on here, and it leads to a severe infection. So severe infection is going to be fight off by your neutrophils are going to be the first to come there. We know that, right? So in severe infection, all of the neutrophils, or most of the neutrophils can come to the site of infection, which would again lead to neutropenia and severe infection. The idea is that most of the neutrophils are leaking out of the blood. So if you look towards the level of neutrophils in the blood, that would obviously be low. So we are going to call again that a neutropenia, right? Okay, so GM-CSF and G-CSF may be pharmacological to boost granulocyte. We know that the GM-CSF and G-CSF basically boost your granulocyte production. If you guys reminded from the pharmacology, we discussed this concept there as well in our immunology, right? Then we have our lymphopenia. What is lymphopenia? Whenever the lymphoid lineage cells, B lymphocyte, T lymphocyte goes down, that's lymphopenia. How do they go down? We know DJOR syndrome. Failure of third and fourth pharyngeal pouch, no thymus. If we do not have thymus, can we have mature T cells or proper developed T cells? Can we train them? Yes or no?
No.
No.
No, perfect. In HIV basically, the virus is going to target your CD4 cells, right? So the count of CD4 again is going to be less. So can I say in both of these conditions, I'm going to have lymphopenia, right?
Yes.
Hello? High cortisol state. If you guys remember your pharmacology, the glucocorticoids, what do? They inhibit the NFK beta, and they would ultimately, inhibit the growth of your both B and T cells, used as immunosuppressant as well. So high cortisol, high glucocorticoids in Cushing disease syndrome, Cushing disease, they're going to be having apoptosis of lymphocyte. We discussed that in detail in our pharmacology section, right? Autoimmune destruction. If we have SLE, what SLE can do, it can cause autoimmune destruction of your lymphocyte, right? So lymphocytes can be depleted in that case. Whole body radiation, again, lymphocytes are still your actively dividing cells. If you are giving whole body radiation, so along with the cancer cell, the lymphocyte levels can also go down, right? So these are the entire causes of your lymphopenia, and that's very simple, right? Okay, then we have leukocytosis. What do we mean by leukocytosis? Whenever the neutrophils count or the white blood cell count increase in the blood. When do we have increased white blood cell? Whenever we have infection, not a severe infection, right? A normal kind of infection. So we know that the white blood cell count would increase in order to fight off that infection, right? Okay, another thing really important. The glucocorticoid, if you guys remember, I just told you in your pulmonary vasculature, basically your neutrophils are hanging, they're attached to adhesion molecule, if you guys remember that, right? The marginated pool of your neutrophils. And we discussed that the glucocorticoids can decrease your eosinophils, they can decrease your leukocytes and every white blood cell except neutrophilia. We'll be having a lot of neutrophils. Why? Because glucocorticoids would disrupt these adhesion molecules, and as these adhesion molecules are disrupted, so all of the neutrophils are going to leak into the blood. We have a lot of neutrophils. That's neutropenia. Oh, okay, that's neutropenia or neutrophilia. Hello,
Neutrophilia.
philia. Okay, perfect.
Yeah.
Okay, so that's a normal concept. How would you know that what things
So
cause
what is the
leukocyte?
reason?
Reason for
Neutrophilia.
neutrophilia. As I already told you, in your pulmonary vasculature, you have a big reservoir of neutrophils. They are just hanging down like beds. If in the cave you just enter, you might be seeing some beds that they're hanging, right? So simply you can think of that these neutrophils are going to be hanging in your pulmonary vasculature through these adhesion molecules. So what the glucocorticoids do, they disrupt the adhesion molecules. That would not let the adhesion molecules to be there. So how can neutrophils then hang? They can't hang. So all of the neutrophils would leak into the blood. So we are going to be having a lot of neutrophils level, neutrophilia. Is it clear?
Yes.
Okay, perfect. So let's just move to our next page. Okay, that's monocytosis. So when do we get monocytosis? These are some simple things you already know the concept. So let me just, okay, when do we get monocytosis? Do you guys have any idea? The monocyte lineage, if you remember from coming from the the myeloid lineage. In chronic inflammation, in chronic inflammatory states and malignancy, the monocyte levels would rise. If you guys remember, we discussed we have something called the acute inflammation and chronic inflammation in the heart module, and everywhere we discussed that. So the first cells which would just come, for example, if someone is having myocardial infarction, we discuss in first few weeks, neutrophils are going to come there. You guys remember that? Same is the case with CSF. If
Yes.
you have any kind of infection in CSF, so for the what would be the acute cells which would rise? Neutrophils. But in chronic phases, we will be having more monocytes,
Lymphocyte.
right? Yes. Okay, lymphocytes as well. And the monocyte and the macrophages coming and just removing the debris and leading to chronic inflammation. And in the end, we have fibrosis and everything. So you guys remember it, right? Eosinophilia, we know that it occurs whenever we have any kind of parasitic infection. We know that, antibodies dependent release of, major basic protein killing that parasites. And along with that, we also discussed that eosinophilia is going to be seen in hypersensitivities, type 1, asthma. Remember? The eosinophil crystals, interleukin 5 for eosinophils, So eosinophils can be seen in two cases. We already have discussed that in detail in parasitic infection or in in Hodgkin lymphoma as well. So we'll be discussing what is Hodgkin lymphoma, right? That's really important to know. Okay, and in hypersensitivities, we are going to be having a lot of eosinophils. And along with that, basophil can also be increased whenever we have chronic myeloid leukemia. We'll be discussing that. It's a really important hallmark seen in chronic myeloid leukemia. So let's leave it to that, okay? Once we are discussing chronic and acute lymphoma and leukemia and everything, right? Okay, so we have lymphocytic leukocytosis. What do we mean by lymphocytic leukocytosis? Whenever we have
Mostly
increased
increase
lymphocytes.
lymphocytes.
Okay, so we discuss your viral and fungal infection needs T cells there to clear them, right? We discussed that in our immunology. So whenever we have viral infection or whenever we have a fungal infection, it would lead to increased T lymphocytes. So we are going to be having lymphocytic leukocytosis. Okay, but the only bacteria which increases the T cells, really important, is Bordetella pertussis. Okay, that's really important because it has something called lymphocytosis, promoting factor which would increase the level of T cells. So speaking generally, we discuss that T cells basically fight against your, yes, viral and fungal
Fungus.
infection. But the only bacteria which would increase the T cells is your Bordetella pertussis. Is it clear? Hello?
Yes, sir.
Okay, perfect. The next topic which we are going to discuss is infectious mononucleosis, and your world is filled of that infectious mononucleosis. So, what is infectious mononucleosis or IM? It's really important, right? Okay, so we have a virus that's called EBV, right? So one thing which you should know, basically, it's a topic of your microbiology. If you guys do it from microbiology perspective, you are going to have a better overview of that. But let me just give you a little bit overview. Okay. Okay, so it's also known as kissing disease. So seen in adults, it transferred through saliva, right? Also known as kissing disease. Once EBV enters into your body, what are going to be the target cells for EBV? Who is going to be telling me that?
B cell.
B cell.
B
Which
cells.
receptor? CD
CD21.
20.
CD20.
21 receptor. Yes, CD21 receptor. Perfect. But an important thing to keep in mind, although they are targeting B cells, but they are virus. In response to that, which cells are we going to see?
T cells increasing.
T
Engaged
cells.
T cells.
Perfect. Perfect. So you should not be confusing it. Although they are targeting your B cells, they're causing problems in the B cell. But we know that in order to fight off viruses, T cells are going to rise. So we are going to be having eight typical lymphocytes, CD8 positive T cells. Really important, one of your UWorld MCQ. So you should not confuse it, with CD21, right? So that's really important. What EBV can cause? It can cause, it can infect your oropharynx, causing pharyngitis, really important. It can cause hepatitis, hepatomegaly as well. And it can also, increase your, the size of your spleen. If we discussed that, if you guys remember, right? In the spleen, we have periarteriolar sheath where we have T cells. So in EBV infection, what would happen? That zone is going to enlarge. And once that periarteriolar sheath zone enlarges, your spleen would enlarge. So as the spleen enlarge, so we would tell this individual to avoid contact spots. Why? Because the spleen is already, enlarged. And for example, if
Discuss
someone just
rupture.
hits
Yes.
them by the abdomen, it can lead to rupture. Really important, one of your UWorld MCQ, okay? They're going to tell you why do we tell an individual with EBV to avoid contact sports in order to avoid
Yes.
splenic
For
rupture,
6 weeks, I
right?
think that's also mentioned.
Yes, yes, 6 weeks. Perfect. So We are going to be having generalized lymphadenopathy, and that makes sense. Why? Because in the paracortex area is going to enlarge in order to fight off virus. The paracortex is going to enlarge a lot of T cells, and this enlarged paracortex is going to appear as a whole enlargement of your lymph, your lymph nodes. Okay, splenomegaly. We know that the periarterial sheet T cells would become hyperplastic, and it's going to lead to enlargement of your spleen. And as a result of this infection, we are going to be having reactive CD8 positive T cells in order to fight off those viruses. We know that, right? Monospot test is used for screening. It's really important. One of your U world MCQ. So if you just test this individual for, let's suppose if you just inject horse or sheep red blood cell, so these individuals will be having antibodies against those horse or sheep red blood cells, which are called heterophile antibodies. Normally, we don't have to make any antibodies against sheep or horse, red blood cells. But individual with infectious mononucleosis can make, okay, simply you can think of whenever this virus just hijacks your B cells, so your B cells are going to go mad. They're going to make everything, even antibodies against horse, sheep, red blood cells, right? Because it's a primary infection of your B cells, right? Viruses are infecting your B cells. So we can have horse or sheep, that's basically known as monospot test or heterophile antibodies. Really important, one of your real world MCQ, okay? So usually turn positive within 1 week after infection. But if we have negative monospot test, it do not indicate that an individual do not have IM. They can have IM, but now it won't be due to EBV. It can be due to CME, cytomegalovirus CME. Okay, but in order to have definitive diagnosis, you should look for the viral capsid. EBV viral capsid. If it's there, you'll just have a proper diagnosis that yes, it's IM. Okay. So what are the complications? As we already discussed, splenic rupture. Why? You guys know the idea. We can have hyperplasia of that periarterial sheath, which can lead to enlargement of the spleen. So tell them to avoid contact spot. We can get rash if exposed to ampicillin. That's also really important, right? So dormancy of virus in B cells, we discussed, is going to primarily infect your B cells. Okay, it can cause B cell lymphoma, which we'll be discussing. What is B cell lymphoma, right? Especially in immunodeficient, in immunodeficiency, like for example, those who are having HIV, the immunodeficient, if they get IM, they can get B cell lymphoma. Okay, so let me just give you a quick overview, and then let me just move to our main important topic, that is acute and chronic leukemia, right? So we discussed what is leukopenia, decreased white blood cell. What is leukocytosis, increased white blood cell. The normal level is 4K to 11K. We know that, right? Leukopenia. How can we get leukopenia? Severe infection, neutrophils moving out. Okay, any kind of cancer therapy can decrease, it can damage the erythropoietic, sorry, the like your hematopoietic stem cell, that can lead to decrease white blood cells. Okay, we discussed lymphopenia and DJOR syndrome and HIV. We know that high cortisol state. We know that was one of the drug to depress. That's an immunosuppressant, depressing your B cells and T cell growth, right? SLE, again, whole body radiation, leukocytosis. Whenever we have infection, leukocyte would rise, and along with that, we can have, administration of glucocorticoids would disrupt that, adhesion molecules, leading to neutrophilia. Okay, high cortisol state, we discussed that. Monocytosis, eosinophilia can be seen in two conditions. We know that in hypersensitivity is allergic condition as well as parasitic infections. T cells can be seen in viral and fungal infections, right? But the only bacteria which increases the T cells are Botulella pertussis, because it's going to release something called lymphocytosis promoting factors. Simple. IM, infectious mononucleosis. The main virus is EBV. It would target CD21 B cells. But as a reaction to that, we are going to be having CD8 positive T cells in order to fight off that ABV. Kissing disease transmitted through saliva. We know that. Okay, it's also going to lead to nasopharyngeal carcinoma. Increases the risk of nasopharyngeal carcinoma. Really important, one of your U world MCQ as well, right? So they haven't just write it down here. It increases the risk of nasopharyngeal carcinoma. Really important. Okay, so EBV infection, we discussed we can have lymphocytic leukocytosis. We know that. We discussed we can have generalized lymphadenopathy. The idea is declared. Why? Because for the T cells, in order to fight off this virus, we can have a lot of hyperplasia of your paracortex, periarterial sheath, which is going to lead to lymphadenopathy and enlarged spleen. Okay. test, monospore test. As they are infecting your B cells are going to go mad. They are going to make antibodies against your horse or sheep even. So if we inject that red blood cells, we are going to be having destruction of horse or sheep antibodies. It is going to confirm it's a monospore test because they are going to have heterophile antibodies, heterophile. Okay. We discussed if it's negative, it can be due to CMV, and the only definitive diagnosis is going to be made through looking for EBV viral capsid. Okay, avoid them to, tell them to avoid contact sport due to splenic rupture. Really important. Again, your U word MCQ. Okay, so that was all. Is it clear? Hello?
Yes, sir.
Yes.
Okay, okay, perfect. So let's move to acute leukemia. Before going into leukemia, whenever you see acute leukemia, okay, what is leukemia? Do you guys know the concept? What is leukemia? What do you guys think of leukemia?
Blood cancer.
Blood cancer. Okay. It's a cancer, leukemia.
Cancer of
Okay.
white
White
cells.
white blood cell cancers.
Okay. You can say it's a cancer of white blood cell. Yes, you can say that. Remember, whenever you see the word acute, it's going to be the cancer of blasts, erythroblast, myeloblast, monoblast, megakaryoblast, lymphoblast, B lymphoblast, or T lymphoblast. The word acute, whenever you see acute leukemia, acute lymphoma, acute anything, acute, it means it's going to be cancer of your blast cells. Whenever you see chronic, it's going to be cancer of your mature cells, like red blood cell, neutrophils, basophil, chronic myelogenous leukemia, monocyte, megakaryoblast, chronic, megakaryocytic leukemia. You can have that. If it's plasma cell cancer, the name is obviously different. I'm going to tell you that. But whenever you see acute, it's basically cancer of your blast cells, immature cell. Is it clear? Yes or no? Whenever you see chronic,
Yes.
it's going to be cancer for your mature cells. That's so simple. Okay. Remember, whenever we get cancer of them, we will be having more than 20% of blast. More than 20% of blast means that it's a cancer of your blast cells acute. So those blast cells would accumulate in your bone marrow, right? For example, if it's due to erythroblast, myeloblast, monoblast, megakaryoblast, if we are getting cancer of these blasts, they would just accumulate in the bone marrow. And as they're accumulating in the bone marrow, let's suppose if we have megablast, acute megablastic leukemia, let's suppose, okay? So it's going to dominate your entire, it's going to grow a lot of cancer. So it's going to replace the other cells. Like it's going to replace the erythroblast, the monoblast, megakaryoblast. So whenever we have this kind of cancer, we are going to have pain, cytopenia. Why? Because the cancer cells are going to replace your entire bone marrow. So the other cells are going to go down because their place is going to be took by these cancer cells. That's really important to know. Okay. So let's refer towards our text, what they are saying. So it's neoplastic proliferation of blast, more than 20%. So now the question should arise in your mind. We have blast in both lineages. We have blast in the myeloid lineage. We have blast in lymphoid lineage. So how to differentiate them? That's really simple. Okay. If we have cancer of the blast cells at the lymphoid lineage, so we are going to, okay, that's a blast, so acute lymphoblastic leukemia. Okay. If we have cancer of the blast at the myeloid lineage, what are we going to call that? Acute myelogenous leukemia. The word acute indicates that it's a cancer of blast. The myelogenous indicates that it's in the myeloid lineage. The lymphoblastic acute indicates blast cancer. Lymphoid indicates that it's the cancer of lymphoblast. Is it clear? Yes or no?
Yes.
Okay,
Yes.
perfect. So as we discussed, these blasts can just replace the normal cells, and it can lead to anemia, thrombocytopenia, neutropenia, pancytopenia. Okay. Okay, so the blasts are really big, immature with punched out nucleoli. We are going to see the picture in a while. So as I discussed, if it's on myeloid, if the blast cells of the myeloid, okay, let me just show you here. If we have blast cell cancer of erythroblast, we are going to list it under acute myelogenous leukemia. Myeloblast, again, acute myelogenous leukemia. Monoblast, acute myelogenous leukemia. Megakaryoblast, acute myelogenous leukemia. D lymphoblast, acute which leukemia? Acute lymphoblastic
Lymphoblastic.
leukemia. Okay, T lymphocyte, again, that's acute lymphoblastic leukemia. Okay, so I think it's clear now, right? So remember one thing. Okay, so if we have these lymphoblasts, let's suppose acute lymphoblastic leukemia or acute myelogenous leukemia, how to differentiate whether it's a myeloid lineage or it's a lymphoid lineage? For example, if you get a blast cell, if I just give you a blast cell and tell you just to differentiate them, so there is a really important feature to differentiate them. That's really important. If you just take any blast from this myeloid lineage, or acute myelogenous leukemia, so that cell would just contain something called OR rods. Okay, AUER rods. Why? OR rods are basically your myeloperoxidase. What are myeloperoxidase? We know in the neutrophils, basically we have an enzyme myeloperoxidase which fights off against your infection. So it's specific. It's basically specific for myeloid lineage, right? So that myeloperoxidase sometimes can precipitate because it's a cancerous, cell. We can have a lot of, that myeloperoxidase, and they can precipitate as a crystal, and that crystal inside the cell is going to be called as OR rods. Is it clear? Yes or no?
Can you please
Hello?
repeat?
Okay, sure. If I just give you a cell, a big cell, blast, and I just tell you, please differentiate whether this blast is from myeloid lineage or whether it's from lymphoid lineage, right? So you have to zoom in the cell. And if you find something called OR rods, that's going to be from your myeloid lineage. What are OR rods? OR rods are basically crystals of your myeloperoxidase enzyme. Myeloperoxidase enzyme is normally present in neutrophils in order to fight off against your bacteria, right? So if you have a cancer of this myeloid lineage, we are going to be having a lot of myeloperoxidase. A lot of myeloperoxidase is going to concentrate, is going to form crystals. Those crystals, you can simply see it in the cell. We're going to be having 4 to 5 MCQs that are going to give you that smear, and you are going to identify the OR rods, right? So OR rods are specific, highly specific for acute myelogenous leukemia, the myeloid lineage. Is it clear? Why?
Yes.
Yes.
If you find something called TDT in the blast cell, it means that it's acute lymphoblastic leukemia. It's either cancer of B or either cancer of T, right? So myeloperoxidase or OR rods is going to tell you whether it's from which lineage. Either it's from myeloid lineage or either it's from lymphoid lineage. If you find myeloperoxidase, if you find crystal of that. If you find OR rods, that's going to be coming from myeloid lineage. If you find TDT, it's going to be from the lymphoid lineage. Okay, that's so simple. But now the question should arise that in
What is
lymphoid lineage. Yes, please. Any questions?
what is TDT?
Okay, let me just tell you. It's a DNA polymerase, right? I'll be just telling you, but just remember this TDT. Okay, there is a DNA polymerase enzyme. TDT, TDT. Okay, just remember that. Okay, I'm going to be, once we are just reading the text, I'm going to tell you that, but it's a general overview, right? Okay, hello?
Yes, sir.
Hello? Okay, perfect. So now, for example, if you find TDT, now again you'll be thinking of that, is it a blast of, it's a cancer of B lymphoblast or is it a cancer of T lymphoblast? So that's really simple. Then you have to look towards the receptors on the surface. If you have TDT with CD21 receptors, what would you assume?
B lymphocyte
B.
Yes, B
origin.
lymphoblast, right?
B.
The cancer is of B lymphoblast. If you just see CD4, then
T
T.
lymphoblast.
T
T.
lymphos.
T
T.
lymphoblast. Perfect. That's simple. Okay. So let's just come towards our text and let's just break it down. Okay. Okay. So you can see that we discuss it's new. Okay. Acute lymphoblastic leukemia. It's lymphoblast, which means it's from the lymphoid lineage, right? Okay. What acute suggests is going to be cancer of the blast. We know that it can either be B lymphoblast, it can be other T lymphoblast, right? And we are going to see something called TDT, right? TDT is going to be present in that lymphoid lineage, and in the myeloid lineage, we were seeing myeloperoxidase, right? Or rods. Okay. So TDT is absent in myeloid. Okay, TDT is absent in myeloid while it is present in, the blast cells of your lymphoid lineage. Keep that in mind. Okay. So it's basically associated with Down syndrome. Okay. So as I already told you, if you just found that it's an acute lymphoblastic leukemia, if you found that TDT, then the other question should be whether it's of B cells or T cells. So we can have either BALL or TALL. BALL mean that it's a B lymphoblast cancer. B acute lymphoblastic leukemia, T acute lymphoblastic leukemia, right? So you're going to have TDT, and what would be the cell surface receptor for B? We know that we can have CD10, we can have CD19, we can have CD20. These receptors are going to tell you whether it's a B cell or whether it's a T cell. Is it clear? Hello? Hello?
Yes.
Okay. Okay.
Yes.
Okay. The other thing, basically we have excellent prognosis to chemotherapy. If you have this kind of cancer of BLL or T, that's basically having a good response to chemotherapy, except that of scrotum and CSF. If you guys remember, we discussed something called the in
Immune
immunology. If you
privilege.
remember, we have immune privilege, right? Immune privilege. It means that
Mm-hmm.
immune cells cannot cross there, right? So if you get cancer, you're going to give this chemotherapy due to that barrier through which the chemotherapy cannot pass through that tight barrier. So you are going to give them separately in the CSF and the scrotum, because we have blood brain barrier, and in the testicle we have blood testicular barrier, something like that. Okay, so we have two variants here. It's really important, right? T Okay, that's whenever we have translocation of 12 and 21 translocation, it's having a good prognosis commonly seen in children. If you have 922 Philadelphia, it's having poor prognosis seen in adults. Just keep that in mind. Okay, it's pure memory. Just memorize it. 12, 21, good prognosis, children. 922, poor prognosis, adults, right? So that was all about DALL. For the TALL, again, it would be TDT positive because it's a blast cell of your lymphoid lineage. And further, we are going to look for the receptor, the low number receptor, 2, 3, 4, 7, right? It won't have 10. 10 is for B. We know that, right? So in this way, you can differentiate whether it's a B or it's a TALL. Okay, is it clear?
Yes,
Yes,
sir.
sir.
Okay, I'm going to have a quick overview in the end. Don't worry, okay? So first of all, you should only just know the main points here, right? Okay. So as we discussed about acute lymphoblastic, okay, let's just come towards acute myeloid leukemia. Acute means it's a cancer of which cells? Yes,
Blast
Blast.
cell.
Blast.
blast
Blast.
cells. Myeloid means it's basically blast cells of your myeloid lineage, right? More
Yes.
than 20% in the bone marrow. Okay, they are going to be having MPO or rods. Why? You know that? Because they are
Myeloid.
Population
specific
of
for
myeloperoxidase.
myeloid lineage, right? Perfect. So crystals of MPO, they are going to aggregate, causing all rods. A really important point, if you guys remember in DIC, I just told you that we will be discussing that thing in our white blood cell module. These ore rods can sometimes leak out of the cell. And remember, once it enters the blood, it can cause DIC. It can activate your coagulation cascade, both your platelets and the fibrin, both of intelligence pathway, increase PTT, PT. We discuss DIC, right? Really important, one of your UWorld MCQ. If the ore rod leak out of the cell into the blood, it can lead to DIC. If the ore rod leak out of the cell, it can lead to DIC. Really important. Okay.
Yes.
Hello. Perfect. So we discussed we'll be having MPO. Okay, it can be subclassified. You know how, whether it's from the myeloblast lineage. Okay, so for example, now we know. Okay, let me just move to this page again. Okay, so here we discuss if you just found TDT, either it can be B or T. How to differentiate whether it's B or T? Look towards the receptor. But
CD.
if we have
Mark.
MPO or rods, so now there can be a lot of variants of them. It can be blast of erythroblast, it can be myeloblast, monoblast, megakaryoblast. How to differentiate them? Now that's our point here, right? How would we know the cancer of each blast? Okay, remember acute promyelocytic leukemia. What is acute promyelocytic leukemia? it's basically cancer of your myeloblast. You know, when this lineage, the myeloblast, become cancers, that's going to be called, what's the name used for that? Acute
Promyelocytic.
pro-myelocytic leukemia. Acute pro-myelocytic leukemia. Okay, is it clear?
Yeah.
Okay. So you can see acute promyelocytic leukemia. Why do we see that? It's basically translocation of 15 and 17. What do we mean by 15 and 17 translocation? That's really simple. Okay. Let me just write down here. Okay. So we have two chromosome 17 and we have chromosome 15. So it's basically going to be translocation of retinoic acid receptor on chromosome 17 to chromosome 15. From chromosome 17, this receptor is going to, the genes for these receptors are going to be added here. And once the cell is making, it's really important for your promyelocytes. Just keep that in mind. So as they are replicating, so we are going to be having overexpression of this receptor as well. So you can simply think of 17 is giving genes to 15 and 15 is working for it on so as it has the genes of 17 and which genes the receptor retinoic acid receptor. So we will be having overexpression of RAR as well. So what would be the problem with that? If we have a lot of expression of RAR, it won't allow the cell to get mature. If increased RAR aren't allowing the cell to get mature, obviously they are going to stay in the blast state. Am I right? Hello?
Yes.
Yes. Yes.
Okay. If we have translocation of RAR from 17 to 15 increase RAR, it won't let the cells to get into their mature state. That is basophils, eosinophils. What else? What else? Granulocytes, right? Okay, so it won't let them to get matured. So it would stay in the blast cell. So if they're staying in the blast cell, it would lead to cancer. A lot of cells in the blast is going to be acute cancer, right? So let me just call it as acute promyelocytic leukemia. So what is going to be the treatment option for them? Give them all
Vitamin A.
transuranic acid. Give them
Okay.
vitamin A, vitamin A. So as you are giving vitamin A, they'll be converting into the mature state. In this way, you can just treat them. Okay, really important. Is it cleared? Hello.
Yes, sir.
Acute
Yeah.
promyelocytic leukemia. Let me just tell you again. We discussed MPO positive. Okay, we have MPO positive cells. Now you should differentiate whether it's a blast of myeloid, monoblast, if it's megakaryoblast. So for that, you have to look towards, if it's myeloblast, acute promyelocytic leukemia, it's going to be having. Okay, so it's going to be having like um, as we discussed, it's going to be having all transretinoic acid receptors. Okay, being moving from chromosome 17 to chromosome 15, right? Okay. So the next one we can have cancer of these monoblasts as well. Okay, we can have, yes. Any questions?
Mm, yes. So how does the increased expression of the retinoic acid receptor cause the promyelocytes to not mature? Like, what's the process?
Oh, so it's basically in genetics. We are going to discuss this entire all of the translocation. How do they lead to? Like we have a lot of in the future videos we are going to discuss. In the future lectures we are going to discuss a lot of these translocation. So if you want to know in detail, basically we are going to do it genetics and biochemistry, right? But till now, it's not necessary. They would never ask you the exact phenomena that how do it cause, right? But the only thing which you should keep in mind, if you have increased retinoic acid receptor, it won't let the cells to mature. That's all. Okay, so once we are doing biochemistry, once we are doing the specific translocation in genetics, we're going to discuss the entire pathophysiology. But USMLE would never ask that things, remember. Okay,
Okay, thank you.
is that clear? Okay. So as we discussed, for example, if we have, okay, so we discussed that, okay, this was our page. Okay. So we discussed that sometimes these rods can just move out of the cell. It can cause BIC. The next one is acute monocytic leukemia. So what is acute monocytic leukemia? If the monoblast get cancer, that's acute monocytic leukemia. But really important thing, the monocyte won't be having MPO. They won't be having MPO. Really important. And along with that, the megakaryoblast also do not have MPO. And the reason is that they do not have nucleus. The megakaryoblast basically do not have nucleus. And you know these enzymes are basically made by you. They are proteinaceous in structure. They are going to be made by your DNA. So if they do not have nucleus, no DNA, so how could they make MPO? Really important, right? So generalized speaking, generalized that MPO is going to be for the which lineage? The myeloblast lineage, because there we have neutrophils. So the MPO is important for fighting off against bacteria. And as we know that the megakaryoblast do not fight against bacteria or any infection, right? So we won't be having MPO in both monoblast or megakaryoblast. Is it clear? Hello?
Yes.
Okay. So these blast cancer cells can, in monoblastic leukemia, they can accumulate in the gums. Really important. They can infiltrate the gums. It's really important to keep in mind, right? Okay. So proliferation of megakaryoblast, again, they will won't be having any MPO because they do not need MPO. Why would megakaryoblast or platelets need MPO? That they won't need MPO because they do not fight any bacteria, right? We discussed MPO was myeloperoxidase, to fight off against bacteria, right? Okay, that's really important to know. So if we have cancer of the megakaryoblast, that's going to be called as acute megakaryoblast leukemia. If we have cancer of monoblast, they're going to be called as acute monocytic leukemia. They can infiltrate the gums. That's really important. Okay, is it clear? Hello? Hello?
Yes.
Okay. So, myelodysplastic syndrome. We are going to discuss myelodysplastic syndrome in details in our first set. It's written there in a good detail, right? So, for now, let's just skip it, okay? Just mark this down. We're going to discuss once we're doing first aid, right? Myelodysplastic syndrome. So, the idea is basically that we can have abnormal, maturation of the cells, which can lead to, cancers of those blasts, but that would be less than 20%. I'm going to tell you there, right? Okay. So this was all about acute. Let's just have an overview and then we are going to move towards the chronic one, right? Okay. Let's just start from very beginning. Let me erase it. I just told you whenever you see, okay, what is leukemia? Leukemia is basically a cancer. Okay. Whenever we see the word acute, it means it's going to be the cancer of blast, right? Now the question should arise that blasts are present on the myeloid lineage as well and the lymphoid lineage as well, right? So if we have cancer of the blast at the myeloid lineage, they are going to be called as AML, right? If we have cancer of the blast at the lymphoid lineage, they are going to be called as, yes, ALL, right? Okay. ALL is most commonly going to be seen in children. CHILDREN, right? ALL. Very important. Okay. Okay. So, how to differentiate whether it's from myeloid lineage or whether it's from lymphoid lineage? If we have MPO positive or rods, that's going to be myeloid lineage. TDD positive or DNA polymerase, that's going to be good. Yes,
Lymphoid.
Lymphoid.
lymphoid
Lymphoblast.
lineage. Perfect. Okay. Now the question should arise, let's just look for lymphoid, whether it's due to B lymphoblast or T lymphoblast. For that, what we are going to do, we are going to look for the receptors, right? If we have
Yes.
receptors of B cells, that's BALL. If we have the receptors of T cells, that's TALL. For the BALL we discussed, we have two variants, 1221, children with prognosis. 922, Philadelphia chromosome, adults, poor prognosis, right? Okay. And for the T, we discussed that you should just look towards the receptor, is going to tell you. Here, let's come to the myeloid lineage. A cell is having MPO, okay, MPO positive, having overrods, okay, so it can be due to proliferation of myeloblast, which we call acute promyelocytic leukemia. Why do we see that? From the 15, from the 17 to 15, all trans-retinoic acid receptor, RAR, retinoic acid receptor, it won't let the cells to get into mature state, so blast would increase. What is the treatment option? Give vitamin A, right? Is it clear? For the
Yes.
monoblast and megakaryoblast we discussed, they won't be having MPO because they do not need MPO. Okay, is it clear? Okay.
Yes.
Yes.
Okay, so the monoblastic leukemia we discussed, they can infiltrate the gums. For the megakaryoblast, what we discussed, that they do not have MPO.
Yeah.
Only that, okay. So I think it's easy. Any questions here? knowing only these like the journal things which I'm discussing, they would never go in depth of these things. Remember, because they also know that students are really bad at it. Okay. So if you know the general concept, how to differentiate them, like you have 2 to 3 cells MCQs on this. We have a cell, it was TDT positive, having a receptor CD21. What do you think? Which one is it? We have TDT positive, we have MPO positive. They are going to give you this picture, right? Okay, let me just show you this picture. And they're going to tell you that, okay, these pictures, you can see the rods here. Okay, it's not clear here. These are your all rods, you can see. These are your all rods,
Yes.
right? So they're going to give you
Yes.
this simple picture, a small pinkish kind of thing. If you see that you have 3 to 4 MCQs in your, just go for, you know, the
Yeah,
myeloid
man.
linear. Okay, acute promyeloblastic or myelocytic leukemia. Okay, so that's all about acute. Let's come towards chronic leukemia. So as I already told you that whenever we have cancers of mature lineage, that's going to be chronic leukemias, right? So it's neoplastic proliferation of mature cells, right? Mature cells. Okay, so again, the question should arise. It can be, on the lymphoid mature or the myeloid mature, right? Hello?
Yes, sir.
Oh,
Yes.
perfect. So let me just, okay, just give me a second. Let me just erase it. Okay. Okay, so chronic lymphocytic leukemia. Okay, so what is chronic lymphocytic leukemia? We know that chronic, it's a cancer of immature or mature cells. Yes,
Mature.
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 Lymphocytic, is it on lymphoid side or myeloid side?
Lymphoid.
Lymphoid.
On the lymphoid side. Perfect. It's on your lymphoid side. Okay. So neoplastic proliferation of naive B cells. Naive B cells, what I just told you there, right? It's mature but less mature as compared to. I just told you if the myeloblast is 5 years, so the naive B cells are 18 years old, right? So still they are mature but immature as compared to plasma cells. That's really important to keep in mind, right? That's really important to keep in mind. Okay. Mature than blast, but immature than plasma. Mature than blast, but immature than plasma. So still they are mature, right? If you are just comparing it with the blast, they're mature, right? So chronic, okay, chronic lymphocytic leukemia, we can have B cells, naive B cells, cancer. So naive B cells are mature. So let's call it as chronic. They are on lymphoid lineage, lymphocytic leukemia. What are going to be the receptor present on them? CD5, really important. Really, it's an exception, right? It's an exception. CD5 is an exception. It's a low number. It should be for the T, but it's not for the T. Here in this case, it's for the B. Really important. And CD20, you guys know that, right? It's the most common leukemia overall. Okay. One thing. Let me just give you a mnemonic in order to remember it. Whenever we have immature people here in our country, what we do, we just slap them. How? We just slap them with, with chappal. Do you guys know what is chappal? With, with shoe. Okay, we just smash them because they're immature. They're doing immature acts, right? And mature people, remember, mature people. They're what's the sign of maturity? Hairs. Mature people are hairy. Remember, right? So hairy people are mature, right? While immature, we have to, in order to fix them, we have to beat them with shoe. Really important. I'm going to tell you that why am I just telling you this story. Mature people are hairy. And what's the other, quality of mature people? They trap people. They can trap people, right? Because they are intellectually really mature, they can trap people. Okay, so now let's discuss. You can see that this B cell as compared to the mature B cell, right? The mature B cells or the plasma, they're immature as compared to them. So what we do with them, we just smash them with shoe, right? Against, so we are going to put them against a wall and smash them, right? Again, and hit them with a shoe. So that would become smudged, right? So smudge cells are really important. Smudge cells are basically, if you just take this cell and just hit it with shoe, it would become a smudge cell, right? So we are smashing this cell. That's a smudge cell. Okay, really important. So in naive B cell, we are going to have smudge cell. They're going to give you the picture of this smudge cell. Let me just show it here. You can see, okay, it's a hairy, right? And where is your smudge cell? Okay, 6.8, 6.8. Okay. So you can see, okay, chronic. So you can see these cells we have just hit them, right? They are the smudge cells. You can see them, right? Okay. So really important. Okay, we discussed chronic
Sir,
lympho.
can you please uh, can you please show the picture again? Mouth.
Okay, okay. You know the pathoma pictures are really bad. I'm going to show it from the U-Board. I'm going to send that in the group, right? So we'll be having better
Okay.
idea about the smart cells. Okay. So we discussed that it can involve your lymph nodes leading to generalized lymphadenopathy. Really important. Generalized lymphadenopathy, and we know why. B cells are present in the follicles. If we have cancer, their lymph nodes are going to enlarge. We know that, right? Okay. And as they are cancerous B cells, they are not proper B cells. So they cannot make proper antibodies, right? So if they cannot make proper antibodies, so we are going to have hypogammaglobulinemia, right? And infections as a result of that. Autoimmune hemolytic anemia, if they are just giving an attempt to make immunoglobulins, that would be defective. Those immunoglobulins can kill your red blood cells. So autoimmune hemolytic anemia is also going to be seen in this case, right? Okay. Hello. Okay, so they can transfer to diffuse large B cell lymphoma. We are going to discuss diffuse large B cell lymphoma, but not now. It's going to be our next topic, right? So there I'm going to tell you the richer transformation. Okay, then we have hairy cell leukemia. For the hairy, I just told you there mature people are hairy, right? So that's basically neoplastic proliferation of mature B cells, and they're going to be having hairs on their surface, hairy cells. Really important. Also called hairy cytoplasm. That is cytoplasmic. We are going to be having a foot-like processes, hair-like processes of coming out from the cytoplasm. Those cells are called hairy cells, right? And I just told you that mature people can trap people, so they are going to be tartrate resistant acid phosphatase. They are going to be positive for tartrate resistant acid phosphatase, right? And another thing which you should just keep in mind, clinical feature includes splenomegaly. Really important. We are going to be having splenomegaly. Why? Due to accumulation of those hairy cells in the spleen, in the white pulp. We can have B cells sitting there in the follicles. So we can have this, these cancer cells there. So simply you can think of that. We are having, trapping. I just told you the mnemonic trap. First of all, they are going to be positive for tartrate resistant acid phosphatase. And the other thing, hairy cells are going to be trapped within the spleen. So the spleen is going to enlarge. Hairy cells are going to be trapped within the bone marrow. So it's going to lead to bone marrow fibrosis, dry tear, right? And lymphadenopathy is absent. It's absent. Really important. One of your UWorld MCQ, they're going to tell you, they're going to give you this case, and they're going to tell you have splenomegaly without lymphadenopathy. What's your diagnosis? Hairy cell leukemia. Okay, is it clear? So we discussed neoplastic mature B cells. They're hairy. They trap. Tartrate acid resistance acid phosphatase. Hairy cells are trapped within the spleen, so spleen get enlarged. Hairy cells are trapped within the bone marrow, so we are going to be having fibrosis of bone marrow, dry tap. What's the treatment option? Give them cladribine. If you guys remember, we discussed the adenosine deaminase. That was basically really important for, in order to save your cell from that adenosine. Whenever it combines with amine, they can damage your B cells and T cells. If you guys remember, what was the condition we discussed? Severe combined immunodeficiency syndrome, right? SCID, right? So we can have, if we have deficiency of this enzyme, both the B cells and T cells are going to die, right? So in this case, we are having cancer of B cells. So we are going to inhibit that enzyme in order to kill those B cells. So there, that was a problem, but here we are using that problem as a therapy, okay, by giving cladribine. So cladribine is going to inhibit your adenosine deaminase, and as they inhibit, you can have toxic accumulation of these adenosine, with amines, and it can kill those cancer cells. That's all. Okay. So let me just again give you an overview of this. We discussed chronic leukemia. Chronic leukemia is cancer of mature cells. Chronic mature leukemia. Now the question should arise whether it's going to be on lymphoid lineage or myeloid lineage. So if it's chronic lymphocytic leukemia, it's on lymphoid lineage. We can have naive B cells there. We can have mature B cells there. Naive B cells still are little immature, so we have to slap them. Smart cells, right? generalized lymphadenopathy is a cancer. They're going to make antibodies against our own blood cells. They're going to be making defective antibodies. A gamma globulinemia, severe infection. Hairy cells, mature B cells, hairy, and they trap people. Hairy, mature hairy people just they trap. Okay, so they're going to be positive for tartrate resistant acid phosphatase. They're going to be having trapping of those hairy cells within the spleen. So splenomegaly without lymphadenopathy. It's really important. You word MCQ. We're going to be having bone marrow trapping with the bone marrow, which is going to lead to bone marrow fibrosis, dry tap. Okay. Treatment option, the one which was causing problem in SCID is going to save you here, right? Give them cladribine, inhibit deaminase, adenosine deaminase. So it's going to be the adenosine is going to, adenosine combined with amines is going to build up to the toxic level and it will start killing these B cells, which is going to be really helpful for it because it's a cancer. Simple. Okay. Hello. Now, yes. Any questions?
What is TRAP and why is it positive?
Why is it?
Why is it positive and what is it?
Okay. So again, let me just tell you that you don't have to get into the details of what is tartrate resistant acid phosphatase, but you would never be asked, right? It's a really complicated, mechanisms of each and everything. But trap tartrate acid, you're only going to be asked. We have cells with tartrate resistant acid phosphatase. Like you can see, there are a lot of dyes as well in the first chat. So if you just keep on going into the biochemistry and the microbiology portion, so things are going to get a lot of complicated, right? So just remember trap, make it easy for you, right? Hello.
Okay, it's just that it might make it easier to remember, I guess. So that's why.
Okay. Okay. So I'll just okay. So
Just
I'll
a
just
brief
look at.
overview about it.
Okay, so personally, I haven't looked into this target race. I'll just look it into it, and tomorrow I'll just tell you the entire, details of that. But trap, just
Yeah,
remember
just
trap.
a brief detail would be fine. Like I don't want anyone to get confused.
Mm-hmm.
I just
Okay.
want to know like
So
why
I
why
can
is
just
it
give you an overview tomorrow. Let me read it first, okay?
okay, thank you.
Okay, I don't want to just tell you something by my own. Let me just read in detail that why is trap, what is it used for, and why do we have positive or negative. Then I'm going to tell you that, okay? But you would never see any MCQ related to trap phenomena. But yes, I'm going to tell you that, okay? So then we have adult T cell leukemia. Believe me, in this chapter, in this topic, if you only know the classification which I just told you, right? You can answer each and every MCQ. You can answer each and every MCQ if you only know the classification, right? Okay. So adult T cell leukemia. Okay. So we discussed for the B cells. Now let's discuss for the T cells as well. Okay. So I think the time is over. So this mucosis fungoid is really important. And in every NBME, you are going to have an MCQ from this mucosis, mycosis fungoids, right? So let's continue it tomorrow. So we are only left with a few things, the easier one, polycythemia vera and lymphomas. So we are going to finish this topic within 2 to 3 days. I also want you guys to have an overview of first aid, right? So after this, we are going to move to first aid. So and within this week, we are going to finish off this hematology module entirely along with the pharmacology. Since it's a big module, it was really big module. So don't worry, other modules are going to be really small like MSK. We're going to finish it soon. After that, we have a big challenge that is, your neurology. And I am planning that you guys should be, revising your entire things which we did because there are probability to that I should just announce an NBME after after your neurology. Okay. So we'll be taking an MBME after neurology, right? Hello? Is it clear? Okay. So let's
It's not
continue.
all
Mhm.
the modules.
Sorry?
NBMB not after all the modules.
Okay, so basically, the idea is like there are two important, a really big importance of taking NBME after your CNS. First of all, you would like we have a lot of NBMEs to practice. You will just get an idea which kind of MCQs because your U world is different than NBME. First, like it's not going to be for your assessment purposes, right? Okay.
Okay.
Hello. I want you guys to have an overview how NBME look like, so that you. Hello.
Okay, sir. Okay. Thank you.
Hello? Okay.
Just for
So you guys should
assessment that now, what the level we achieved and how much the percentage, and what we know the for further future, after this NBME assessment.
after NBME assessment, you guys are going to have an idea how your NBME would look like. You guys will have an idea which subjects or what you guys have to fix, right? So that's the only goal of getting and doing NBME. At least we should do 2 to 3 blocks, right? 2 blocks of NBME. So I want you guys to have an idea of NBME because after that we are only left with 3 to 4 major system, right? Then we have minors. Like after CNS, you can just think that we are almost at the end, right? So I want you guys to be a little bit prepared mentally, for the NBME. So it would just boost your study as well, right? So that's the important. So we'll be taking an NBME, and that's a must. Everyone should participate in that, right? We can just take an offline NBME, no need of online, but you should be having an idea that where are you standing. Maybe if you have to fix something in your study approach, you can just do that in your future, in your revision session and everything, right? So that's the main idea of taking an NBME. It's not for your assessment purposes, right?
Okay, sir.
Yes, doctor.
Thank you.
Okay, for the assessment purposes, we are going to take it in the second phase, right? Once we are done with the entire system, we are done with psychiatry. Every week we are going to be having NBME. I'll just announce the NBME, not now, right? Still we have, okay, which NBME would you recommend now? I'll just announce them. I'll just discuss it with Dr. Moaz. I'll just discuss it with Dr. Maheen and Dr. Hassan. Then I'm going to announce that, okay, that which NBME we should take. Okay.
Okay, sir. Thank you.
Okay. Thank you so much. Thank you and see you at tomorrow. Okay.
Hello?
Thank you so
Yes,
much.
please.
Okay, so can you please send yesterday's recording, please?
Okay, sure. I'll just send it now. Okay. I'm really sorry
Thank
for
you.
the delay. Thank you so much.